Hi, everyone, and thank you for joining us for our today's webinar focused on adolescent healthcare visits during the times of COVID and how to navigate communicating with adolescents. Today, we'll have Dr. Jonathan Fanberg presenting on this topic for us. But before we hand it over to him, I'm just going to cover a few logistics with all of you. So just a few webinar logistics as we usually go through. You are in listen-only mode. So we ask that you use the Q&A function to ask questions or make comments. You can find that in your toolbar. Your video screen size and location is adjustable, so you can click and drag it around. And then if you are joining by phone or if there's multiple of you at the same computer, we ask that you either type your email address and name into the chat window, or if you're joining by phone, if you can email milam@mainmed.com, that will send Mary an email for your attendance records. We are offering CME today, and today's speakers do not have any relevant financial relationships with the manufacturers of any commercial products and/or provider of commercial services discussed in this CME activity. CME is available for participants who have signed into the live webinar. So again, that's why we ask for your name and email address typed into the chat box for the attendance records. And once the webinar is ended by host, you should get a pop-up screen that immediately directs you to a survey, but we will also send out the survey link in a follow-up email because on some computers that pop-up is blocked. So you will get a survey in the follow-up email as well. So if you don't get it right away, don't worry about that. And again, if you have any questions about the CME process, you can email Mary at milam@mainmed.com. Funding for today's webinar was actually kind of a collaboration. It was provided by Department of Health and Human Services through the Main Care Office, as well as Access Health. So our speaker for today is Dr. Jonathan Fanberg. He is a pediatrician and adolescent medicine specialist who has worked in Maine for over 20 years, seeing children, adolescents, and young adults. Presently, he is the director of the Division of Adolescent and Young Adult Medicine at Maine Medical Center. Along with seeing patients, he works with school health, substance use, adolescent gynecology, eating disorders, and resident and attending education. He also is on the executive committee for the section of adolescent health for the American Academy of Pediatrics. We're very lucky to have such a wealth of knowledge as a resource in our very own state. So we thank you, John, for doing this webinar with us today. And I will turn it over to you. You are on mute still.
No, I'm not on mute.
Perfect.
So thank you. I love this topic. So thank you for asking me to speak on this topic of adolescent health and young adult health, which is also included in that age group. With webinars, they're a little more challenging or interesting or unique in certain ways. And the Q&A we'll do at the end. You're welcome to chat whatever you want, but the chat's hard to see while you're presenting at the same time with slides and so much limited geography on one's web page here. So the goals of what I'm trying to achieve during this next 45 minutes, an hour. One is to review what risks should be screened for in all adolescents. 2 is to discuss how to be effective with getting that information. 3 is to appreciate how to be sensitive to gender diversity. And 4, not 3, to talk about why teens are particularly good fit for telehealth and what's going on with the COVID crisis. So next slide, please. So before I start off with how to go about doing it, you need to recognize that adolescents do take risks. And Caleb kindly supplied to me the YRBS most recent report in 2019. And the YRBS is youth risk related behavior score. It's something similar to that, which is done once a year on all high school students. And they fill out a survey that looks at all the risk factors and self-report, but it's a pretty good marker. And what's interesting with this marker is this is a marker that they do every year. So you can watch for trends over time as far as youth risks. And they look at the highlight things such as alcohol use and substance use, and they look at sexual activity, and they look at things like mental health type things and obesity and other topics like that. So there's really good data out there that adolescents do take risks. Next. It's important to also understand where they take those risks and how to simplify it, because if you understand where they get injured, you're able to address those things. Those are unintentional injury, intentional injuries, substance use, sexual behaviors, psychiatric illness, mental health, and weight. And so that's where we really want to be targeting when we're looking at adolescents on those things. Next, please. There's a little bit of a challenge for our slide to fully understand, but adolescent visits to doctors drop over time, and that's the main thing you need to get out of it. Specifically, if I dig down to the details there, if you take a 9-year-old, 45% of them come in for well visits. That's the top green, olive green color. And 22% of them come in over the last year for acute visits of some sort, but not a well visit. And that's the middle bar. And then the last percent don't come in at all over the last year. And what you see over time between the 9-year-olds, where 45% get well visits, compared to the 16-year-olds, 35% get well visits, and the 21-year-old, only 15% get annual visits, that they're tapering off on your access to them. And what that means is you can't hold off for the well visit to touch base on all these things. You need to grab them at any point you can. And even in that 21-year-olds, who you're getting the well visit and the acute visits, you're only getting 31% of your patients. And so that means 70 or so percent you're not even touching base with. And that's a challenge. We need to increase our well visits the best we can. We need to take advantage of any acute visit or touch point we have with patients. And at some point, we actually need to think outside the medical model and say, how do we screen for these things and address these issues in non-medical settings, which I'm not going to address today. Next slide, please. We do talk about these hot topics when we have patients in the office. The Adolescent Health Consortium is a project that American Pediatrics did in 2017. And what they did was they did an online survey of thousands of adolescents and young adults. And they asked them questions about what happened at their last doctor's visit. And about 40–50% of the time, we do talk about substances, tobacco, alcohol, sexually transmitted infections, birth control. What that also says is 40–50% of the time, we don't talk about those things. And that's the concern. We're missing these. Next slide. And in that same survey, they determined that we also don't give them private time all the time. In the 16-year-olds, we give a privacy time about 40–50% of the time where we have the parents step out of the room. But that means 40–50% of the time we don't give them one-on-one time. In the 26-year-olds, fortunately, 80% of the time we do give them one-on-one time. But that also means that 20% of the time the patient is still being reported to have a parent in the room. And that is where the American Pediatrics said we need to address this issue as far as one-on-one time. We need to address the issue as far as providing confidentiality, because we know that we get better data out of kids if we give them confidentiality versus if we don't give them confidentiality. And we need to directly talk about what should be happening in the room when we have that one-on-one time as far as content of mental health, substances, things like that. Next slide, please. And confidentiality, 40–50% of the time, 60% of the time we give confidentiality in that same survey, and once again, 40–60% we don't give confidentiality. On the note of confidentiality, it doesn't matter how you say it, whether you say it verbally or have a poster on your wall, but if you do give some sort of confidentiality comment, you'll actually get more information and better information from the patients statistically. Next, please. So asking the questions. Sometimes a teenager may come in and tell you everything you need to know. You don't have to say one word. But I gotta say, on average, that's not the case. More often than not, you need to ask the questions. And many times it works well to have some sort of mnemonic, which you can remember what to ask. Heads is one of the ones that's written up in the literature quite a bit. More recently, they've shifted the letters around towards shades and put that last S at the beginning. So it's still all the same letters. But if you ask the questions as far as where the risk factors are, you'll get the answers. So specifically along those lines, digging into them. H, it stands for home. Who's in the home? Do you have 2 homes? Do you have 1 home? I seem to be getting pinged by something. Do you have 2 homes? Do you have 1 home? Do you have a fighting family and a family that's going through divorce? That plays an influence on one's health as a teenager. E for education, what grade you're in, what your grades are like, how the grades are changing over time. I worry about a kid who is an all-A student suddenly becomes a C student. I worry about that person more than somebody who is a C student all the time and continues to be C's, because changing grades is a major red flag for something else going on. A for activities. There's really good data saying any activity puts you at better risk for pregnancy, less risk for substance use, less risk for risk taking during the teen years. And there's very good data saying that self-esteem improves by doing extracurricular activities. In the world of COVID, I don't know what to do with this one because we've chomped out 50 to 75% of extracurricular activities. And that's an unfortunate thing. We need to somehow figure out how to replace that without social isolation occurring. D stands for diet and drugs. The D for diet being, are there eating disorder issues that are coming up or obesity issues that you should be addressing? And D for drugs. S for instance for sex, who you're having partnerships with, what's your identity as far as gender identity, and are you risk taking or are you being safe if you're having sex? And S for suicide and what's happening with mental health. Next slide, please. So if I look at all of these things, I want to fast track my interview, which I shouldn't do, but sometimes I'm forced to do. Or if I'm trying to tease out what I need to cover at every visit, it's the drugs or substances, the sex, and mental health. Because those are the three things that you're being measured on. Those are the three things that are going to have the most importance as far as outcome for kids. And those are the things probably the most sensitive that they're not going to share unless you bring these topics up. And those are the three things that keep shifting. And so if I'm seeing a kid once a month for anxiety, I actually might ask about all three of those things every time I see him because sometimes things changed from one month to the next. And that last ask, although I left it to the end, it ought to be the top one on my list because that's the most important thing you can ask about, strengths. Strengths are the way you're going to fix any of these risk factors. Strengths are the way that you're going to propel a kid forward. Strengths are the way you're going to engage a kid and actually being interested in working with you. And so it's very important to not only highlight those strengths, but when things are down and bad and they're doing all these other risk things, how do you convert that all to make it positive for the strengths? It's important. Next slide, please. On that note of strengths, people have looked continuously out over the last 20, 30 years as far as saying, how do you make resilience in kids? And it's these strengths that do it. But in particular, one set of studies looked at 44 strengths, the Search Institute. They called them assets at the time. And they said, if you had 44 resilient features in you, what are the most important ones? And they identified these 7 being support, empowerment, expectation, boundaries, time, education competencies, values, social competencies, positive identity. I don't expect you to remember this list of things, but you'll see some common themes in the various institutes that are out there that have looked at resilience and to be aware of them. But more importantly is my next slide. And my next slide shows that the more of these assets you have, the more likely you're not going to be having problems with violence, not going to have issues with sexual activity, not going to be using alcohol or tobacco, less likely to have school problems, less likely to have depression or attempted suicide, and less likely to use other drugs. And so that's the important thing. I'm not sure which are the best strengths overall to have, but I know the more strengths and resilience you get, the more strengths you have, the more resilience you get out of that. Next slide, please. Other organizations have taken these same resilience pieces and put it into different words. And that's why I say there's some uniformity in themes that come across the various organizations. But this is one I just bring up because this is the one the American Academy of Pediatrics supports, the 5 C's. And specifically, they say contribution, confidence, competence, connection with your family, society, and character. And to somehow be pushing these things as strengths or identifying these strengths in any one individual and saying, where can you be stronger in the ones you don't have the same way? And my next slide. This is the one I like the best because I've used it for the most number of years. It's called Circle of Courage. And it looks at 4 strengths. Sense of generosity. Do you give back to charity? Sense of belonging. Do you have a community like a coach that you can listen to for a parent role model, or a pastor or a teacher or somebody who's a role model for you who can play the role of a parent? It might be a supportive when you're separating from parents. A sense of mastery. Do you do something good? I don't care what it is, but something. And independence. Are you given enough opportunity to test the water as far as what you do and what you don't do, but not get in trouble with those things? And typically with somebody who's at a well visit, I will look for those 4 things. And if I'm seeing that there's a gap in one of those things, I say, hey, we can make you even stronger by looking at how do you get a better relationship with somebody in your community, or how do you give back to the community through generosity or something like that. But the next stop that I want to touch upon is gender and how to be sensitive with gender. Can you move forward 2 slides, please? Gender is a new world compared to 10, 20 years ago as far as how we handle it in the medical world. We're getting smarter about how we do things. We have a long way to go still. There's whole sorts of terminology coming up. There's all sorts of patient requests that are coming up. Identity is changing in various levels. And to that extent, we need to keep up with the changes in what we're doing with our office. Next slide, please. I like this one slide called the genderbread person a lot. And the reason I like it is because it shows the spectrum. And it's the recognition that any one person can have gray shades of a lot of things. They can have varying degrees of gender identity. They can have varying degrees of which gender they're attracted to. They can have varying degrees of what their body parts consist of, the actual gender pieces biologically. And they can have different levels of expression as far as how they portray themselves. The most important piece is recognizing what the patient wants is the most important thing. And so my question is, what does the patient want to be called as far as a name, okay? How does the patient want to be referred to? He, him, she, her, something else, they. What does the patient want in the chart? And so they might want to be called one thing, but want something else to show up in their chart. What does the patient want to share and with whom? And so I have one patient where every time I see the patient in the room, I call the patient Tom, I make up the name. Every time the mom's in the room, I'll call the patient Teresa, okay? And to keep track of all, it's really hard. But if you really want to do the best job to the patient, it's recognizing that piece. Next slide. This is the same genderbread slide. It's one version earlier, but I liked it a little bit better just because it shows the grades. There's lots of shades of any one of those 4 criteria that one's looking at in any one patient. And so many times holding up a slide like this to a patient and saying, where do you stand on gender identity? Which extreme or the other extreme? Where do you stand with expression? Where do you stand with biological sex? Where do you stand with sexual orientation? When we first started talking about this in our system said, oh, this can be the rooming person's job. They walk through these things, a checklist, we'll put it in the chart, we're done. And then we realized that's not in the patient's best interest. We don't want to out people inappropriately or untimely. We want to be very sensitive to what their needs are and what their interests are as far as who knows what. The patient might be very comfortable telling you one thing, but not want your staff to know about it. And so we need to be sensitive along those lines and to adapt to those pieces. Next slide. Why is this all important? Because of health disparities that exist in gender type topics. And whether it's LGBTQ or it's transgender, these are all issues that come up. And specifically, people who are dealing with gender have greater discrimination with housing, with health insurance, employment, marriage, adoption, and retirement. People who are dealing with gender issues have lack of laws for bullying in schools. They don't seek preventive services to the same degree because they're fearful of the medical system. They feel like the medical system has served them wrong. They don't get HIV and STI screening the same way because they're not seeking care from the medical system. So they're more likely to have these diseases that go on for longer before they're treated. They're more likely to run into risks with obesity, more likely to run into risks with partner victimization or violence or rape. They're more likely to have mental health issues such as depression or suicide. And they're more likely to have tobacco, alcohol, and drugs. They basically have almost every health disparity out there in disproportionate frequency. Have the next slide. One of the most critical things that I want to hone in on is this attempted suicide rate. So how your family and society around you accepts whatever gender you identify is critically important. And specifically on the left there, if you're accepted by your family, your risk of suicide is about 4% as far as attempted suicide. If you're not accepted by your family for whatever you identify as, your risk of attempted suicide is about 57% for transgender kids. And this is a huge difference, but also horrifying in the fact that that 4% is the same as the regular population. So if your family accepts you, your risk of attempted suicide is the same as the rest of the population compared to if they don't accept you. And I bring this up to parents whose kids are identifying as a different gender than they were biologically assigned at the beginning of life. On a regular basis. Okay, the next. Our tools in our computer are starting to help us with this. And I bring up Epic because that's the one I work on. I'm hoping that other systems, EMRs, are also doing the same type of thing. But Epic, as of about 6 months ago, has the sexual orientation page. And the sexual orientation page allows you to check boxes that might be appropriate to the patient. I'm cautious with how I check these boxes. And specifically what I mean by that is I let the patient know that we have this section of the chart, and I ask them, do we want to check these boxes together? And I'll pull it up in front of them and I'll say, how should we check these boxes? Because once we check these boxes, yeah, we can change them, okay, but everybody else in my department, my office can see these, okay? And it's a sensitive part of the medical piece, but it is visible to other pieces in the medical system. And so it allows for one to identify their orientation, allows one to identify their gender identity. It allows us to record what their sex was identified or assigned at birth. It allows us to put the pronouns that they prefer. And what's nice is those pronouns will carry over to many of our templates when we print letters or other things like that. Next slide, please. It allows us further down on the same page to put the organs that exist in this patient and how those organs are changing over time, such as this patient had top surgery. And so I can say initially there were breasts at birth and the breasts are not there on the current organ inventory. And I can check these or change these as they occur over time. The last topic I want to touch upon is COVID and telehealth and recognition of how we can use telehealth with adolescents, young adults. I think it's great. This has opened up new avenues for myself, for my system, for my patients, which is phenomenal. There's a couple of things that we've noticed as we've started using telehealth. And we use telehealth probably in about 25% of my patients, and I think that's here to stay even after COVID's over. But picking the right patients is important. And I think telehealth is great for mental health issues. I think telehealth is great for dermatology things, and sometimes they have to supplement that with a photo that comes through their electronic medical record report. I think it's great for non-contact visits where you don't have to touch the patient. I think it's great for college kids. Okay, suddenly I had in the past college kids I could see 6 months of the year, and then I trade off and share with this college nurse 6 months a year. Now, as long as COVID's going on, I can practice across state lines, and all college kids after COVID's over, that cross-state line thing might become an issue, which we might have to curtail. And I think it's great when people live distances from far around the state. And so as an adolescent medicine specialist, I'm now consulting on patients from farther than outside the Portland area. We were seeing patients from all over the state previously, but now it's greater along those lines for consults. And so we open our doors for that as well. I think it's not so great when people need an exam as part of the picture, and that's where things fall apart. And then as you saw me do with the first video, as far as a Zoom visit, that would have been exactly like a Zoom visit. Describing the confidentiality policy, what your medical record policy is, your billing policy is very important as part of the process. And document that in your notes. Next slide. Setting the stage is really important so everybody knows where to go. And just like in my office, I tell parents and kids, okay, I'm going to see you both together and I'll see your kid alone for a period where it's going to be confidential and I'll have the parent come back in at some point. Same thing with telehealth. And I'll set the stage. I'll make use of Zoom's waiting rooms, and we use Zoom presently at least the most. And there's a waiting room in Zoom where I can send the parent out to the waiting room, and they might be at a different computer in the same building, or they might be at their work on their computer, and then bring them back from the waiting room. So it's with some frequency, I'll involve parents on the same Zoom visit and bring them in and out of the waiting room or have them at different sites or things like that, or plain old step out of the room. I also say along those lines, for privacy purposes for the kid, they might want to put some headphones on because parents hear down the hallway what's going on if they really feel it's going to be sensitive stuff. And I'll ask them in the beginning of the visit, like, do you feel like you have confidentiality and privacy where you're sitting at the moment in recognizing somebody's in another room? Telehealth's opened my eyes to a whole nother set of things which I never knew existed. Usually as part of my visit, I will say, tell me something in your room that you're proud of. Okay. And usually say, oh, I'm in my bedroom or I'm in my college dorm or something like that. And I'll get a tour of their college room or their bedroom and with highlights of what's their fascinating thing or their uniqueness or their strength, as I might find in some cases. So I saw a guitar on one kid's wall. I was able to talk about that. I saw somebody was using paint chips on a wall as far as collage. And I said, that kid's autistic. And sure enough, she said, yeah, that's my painting theme is using paint chips from lots of different colors. And then I also saw some words that was graffiti on a word was like something like hate myself or hate something like that. And although I knew the kid was depressed, it gave me more highlight how intense it was. And the kid might be brainwashed themselves to validate that type of feeling of depression. So I've had better insight just being able to get into their homes. And then don't forget about routine preventive health if you're doing Zoom visits. For the CRAFT and PHQ-9, you can share your screen and you can go through a checkbox type thing with that. And that's a successful approach. I dream about the day where I can send somebody a survey through their electronic portal and they fill it out beforehand and it's available to me when I begin the visit. That day hopefully will come. And don't forget there's some routine preventive mental health that still needs to happen even if you're not seeing them. And that's the chlamydia testing or immunizations, which might be the most valuable part of adolescent visits. And those could be done through clinics. If your clinic has set up a shot clinic, just to come by, get that, go on, or it can be done by drop off urine or vaginal swab for chlamydia at a local Nordics lab, as it might be, or whatever lab you have locally instead. So there are ways to get around that as well. Next slide. So I've talked a lot. I think I've left us a couple minutes for question and answer. I don't know if we can take the phone lines off or go through chat or unmute people. I'm happy to answer any questions or things that come up on the slides.
Yeah, so if people have questions, you can certainly start to type them into the Q&A. And then I guess I would just kind of ask John in the meantime while we wait to see if there's any questions that come up. Have you had, I guess, how do you best handle the telehealth visits when the parents may be standing over the shoulder and you're trying to have the conversation with the, I can just imagine like that must be really hard for the teen. So how do you really get those adolescent, like honest answers if you're fearful a parent might be lingering in the back?
Setting the stage is critically important. And that means telling the parent at the beginning with the kid in the room, say, I'd like to talk to you both initially. And I'm going to ask your parent to step out of the room and I want to talk to the kid alone and confidentially. And then I'll invite you back. So we'll summarize things. I recognize there's been cases where I said that and I say, okay, I want to talk to you alone. And the parent picks up the computer and walks out of the room with the computer. And I found myself talking to the parent alone. I said, whoa, no, I want to talk to your teen alone, that type of thing. It's and I do worry about parents who stand outside the door and eavesdrop. And I tone the kid on that, saying, hey, be aware that somebody might be listening through walls or just outside the door. Do you feel like you're in a comfortable spot? Do you want to use headphones? At least they don't know why I'm here. All those things. And then we do the best we can with that piece. I found that to not be a burden or a hurdle, that parents have quickly walked out of rooms. And maybe that's because I have a standing relationship with a lot of these kids. And so they know what they're getting. I know what I'm getting. And likewise, the same thing in my office. It's a very rare parent who won't step out of an exam room. It's a little bit less rare kid who doesn't want the parent to leave the room. So somebody with a lot of anxiety, the kid might say, no, I want my parent in the room. I'm finding with Zoom, actually, they're okay with the parent leaving the room, which is kind of interesting also.
Interesting, and more comfortable with the technology piece. Also, I guess the questions kind of come up a few times. I've heard it in different groups talking about their waiting rooms and how with COVID, are you staging your waiting room? Are you, I mean, it's just hard. People are dragging around chairs, doing different things. So how is your practice handling the waiting room process? Any words of wisdom on that one?
Good question. So presently we are seeing patients in our office at full speed based on what the patient wants. Having said that, we are also happy to accommodate with seeing people with telehealth if they prefer that as well. And for some things like rashes, we're relegating them more to telehealth because we feel like it's a really comfortable, quick approach for them. For some things like COVID risk symptoms, we are not seeing in our regular office. We're seeing them in a respiratory clinic uniquely. And so that can mean a different provider as well. But we're happy to see them by telehealth or happy to give them phone advice without having to see them as well. As far as during COVID or even pre-COVID, we do have waiting areas for parents, which are separate from the exam rooms. They're not just outside the door, they're down the hall and outside the door. And they're in positions which don't have full line of sight as well. So somebody doesn't see me going out to get my pregnancy test done before the parent comes in or things like that. We have also paid attention to recognize that we want to use that space minimalistically, and there's only one person there. And to that extent, we are not using it as much as possible, but still having it available to us. We also have people wiping down those chairs between parent use along those lines. And then what I've also taken advantage of is cell phones. And so there's a number of teenagers who come into my office for a well physical. We do the physical and the parent's out in the car. And at the end of the visit, I will get the parent on the cell phone. Usually I use the kid's cell phone because I know the parent's more likely to pick up their number than my number. And then what I'll do is I'll answer questions to the parent or tell the parent what the summary of the visit was, things like that. So they're still involved. I think it's really important for us to recognize that although we want to give one-on-one time for teenagers and young adults, we also want to involve parents as much as we possibly can because they are the support person at home. If they can provide the same platform and everything at home and that the supportive nature. And so we don't want to shut them out. This is not a game of secrecy. This is a game of getting the kid the service they need. And that's when we provide the privacy if it's going to make or break the difference as far as getting the service they need.
Great. And another question that had come up before that kind of spurred or sparked some of this webinar discussion was really focused around the whole back to school season with COVID coming, with COVID still here, back to school, regular flu, and just providers, looking for any kind of insights as to how they can best handle that. I mean, obviously, use of telehealth as much as possible is probably helpful to kind of limit any spreading. But with back to school, sports physicals, all of that's supposed to be done if schools are playing sports, all of those different things. Have you kind of run into those scenarios? Do you have any advice on? I know I'm putting you on the spot with that stuff.
I think every office out there is overwhelmed with the back to school pieces at the moment. I've been very involved with the school health advisory group for the state. And they've rolled out recommendations related to what it requires to go back to school for various scenarios. This is not separate or unique for adolescents. This applies to all pediatric kids who are in school. We are just hoping that those advisory guidelines are being used uniformly, both by the schools and the doctor's offices, because both have a right to choose or adopt or not adopt those guidelines. But the uniformness will make it easier for everybody at the end of the day. And they are a change. The rule of thumb is if you're sick, you don't go to school. And if you're sick with high-risk symptoms or lots of low-risk symptoms, you get tested before you go back. And it's a lot of testing we're doing, a lot of phone calls, a lot of notes going back to schools, much more than previous years. And a lot of the schools are part of it, which is frustrating. But that's not unique to adolescents. What's unique probably to adolescents is I've been surveying them as far as, are they happy with the remote end 2 days a week or the actual end 2 days a week? And because they're getting hybrid models left and right. It's about a 50-50 split. And that surprised me. Okay? So it's the kids who want to be in school are desperate to be back in school. And they never want school to end again. And they didn't realize that when they had it so good pre-COVID. And the kids who don't want to be in school, typically there's a little bit of generalization. They have more anxiety disorders amongst them. And they're happy as a pig in mud, sitting at home and doing the remote education and doing well with it in some cases. I'm also seeing kids with ADHD don't do so well in the home setting because there's not the structure driving through the homework and other things. But those are gross generalizations without data or studies supporting it fully.
And one more final question. I think we have time for one more. Have you kind of, obviously, likely there's a trend in increase of social isolation. Do you have any tips on conversations around talking about social isolation with adolescents especially?
It's a problem. What I struggle with the most is extracurricular activities, as I alluded to. But I recognize social isolation is a problem. It used to be part of my interview and saying if somebody was socially isolated, that was a problem. And now I got to say that's a good thing in part because it's safe. Having said that, we need to find alternative approaches. And so whether they're Zoom chatting with friends or doing things virtually or doing distance walks or distance type activities with a small cohort of people, somehow we need to replace the process of seeing nobody at all. And so that's an important piece. We also have seen a huge uptick in anxiety in general and requests for both consultations related to that as well as consultations from our counselors. And so we have a very strongly integrated approach between the physicians in our office and our counselors in our office and how to fast track people into the counseling approach as far as how to work with anxiety and how to deal with those, whether it's COVID anxiety or back to school anxiety or isolation and all the moods and things that come with it. Families have had mixed happiness being all at home. Some have loved it because they actually have more one-on-one time with their kid than they've ever had, and some are chewing each other's skin and don't have enough space. And that's a balance which is hard to deal with. I'll throw it up. Oh, sorry, go ahead.
Oh, no, I was just going to say, and with the more online connection, do you have conversations with adolescents at all about online safety and pieces like that?
Yeah, so hey, let's go. People are gonna hate me, but the 2 hours a day is hard to achieve during COVID when it comes to screen time. And even with that, the American Pediatrics nationally has been moving towards it's not the 2 hours, but it's the quality of the screen time that's the more important thing. And to some extent, we're trying to push parents to recognize not necessarily the quality, but understand the content of what your kid's using, and maybe that you're actually spending screen time with them so you understand it better. And so I have Snapchat and Twitter on my phone because I have some young adults in my life who taught me how to use it. And I'm doing that so I can interact better with them along those lines. Same thing for gaming, that I'm recommending some parents actually do some of the gaming with them as they have teachable moments and they understand what they're doing as far as gaming. Or how can they be smart users of media instead of just plain old maximum users of media. I threw out one other topic just because it's a cutting edge new thing is my chart. And I just heard this morning, I'm excited after 3 or 4 years trying to achieve it, is that we're likely to have portals for parents of minors so that they will have limited access to their kids' medical record. And it'll be with the recognition that they'll be co-players with their kids' care. They won't be able to snoop in on everything, but they will have access to them. I've been working on this for 3 years now. We're hoping the other piece that might come with it at some point is that the kid has access to their own chart. And presently within the main health system, they have access down to age 17, which is new as 6 months ago. Before it used to be 18. But that 12 to 16-year-old still is kind of in limbo, and we're hoping that they get some limited access, mainly messaging to the doctor. And if they can get messaging to the doctor, that'd be a huge gain for a teenager.
Great. Well, thank you. We're out of time for today, but thank you for that. And if people have additional questions, they can definitely reach out to myself. My email will be kcole@mainmed.com or Dr. Fanberg. But thank you for presenting on this. I know there's often a lot of questions around the adolescent population, so we appreciate your expertise. And for everyone, the survey link is in the chat, but again, we'll send it out after the webinar as well. And you can complete that survey to download your CME at the end.